Hello, my name is Cindy Kraft. I'm an owner here at K&K Healthcare Solutions, and the only face you will not be able to see today. The internet gremlins are giving me fits with my camera, but that's fine. My role here today is moderator and not a core presenter, so no really harm or foul at not being able to see my smiling face today. I'm here to set the stage and welcome you to our event, Advocacy in Action, a panel discussion. So why are we presenting this today? This came about from many discussions that started with Sherry, my business partner, and myself, really looking at advocacy efforts that are coming from a variety of different directions. We see them come from professional associations. We see them come from beneficiary groups. We see them come in ebbs and flows, particularly when there's going to be any sort of substantial regulatory or payment change. But sometimes what really strikes me is that, as an example, when we have an open comment period for a significant piece of legislation, we know that there's over 10,000 home health agencies in the country. So when we start saying, wow, we had a good turnout of comments, there were several hundred, I always would think, wait a minute, if there's over 10,000 home health agencies, shouldn't there be at least 10,000 comments? I mean, wouldn't someone, even just one person within an organization, have a thought that either say why they thought this was a good move or not a great move? That would really represent the industry. But sometimes we've been, barely at 100 comments. And I don't say that in a way that says, oh, people aren't doing what they're doing and that kind of thing. I just think that we have to figure out how to get this kind of messaging down to the front line of our home health agencies, to those nurses and therapists and aides and social workers who know better than anyone the impact these rules and these payment changes have on the beneficiary, the challenges that beneficiary faces and their family faces trying to manage their care. And yet very often, I think those are the folks that assume that the boss will make the comment or their professional association will make the comment and don't really engage in a meaningful way. So what we wanted to do is take some of our strongest, some of our best friends in this advocacy space and really put together an opportunity to talk about actionable, practical things people can do to make sure we're making our voice heard from both the industry perspective and from the beneficiary. So our panel today is my business partner, Sherry Teague, Summer Napier, who's going to speak with respect to advocacy for the industry and her heavy involvement in that space. Judith Stein, who has been advocating for the beneficiary for a long time now and a huge part of the Jimmo versus Sibilia discussion. And myself, like I said, I'm the moderator. I'm just here to keep things moving. And if you have any questions for any of our speakers, please go ahead and type that in directly into that Q&A box. I will be moderating and facilitating that as we go. If you're listening to the recorded version, our email addresses are at the very end of this presentation, which we will make available to you as well. And you can ask the questions at any time. So without further ado, Sherry, I want to turn the platform over to you.
Thanks, Cindy. I really appreciate it. The reason I came up with this idea and the reason I think that it's important is I know many of us feel like that our voice doesn't matter in the home health space. Well, as providers of home health and as either clinicians, administrators, managers, owners, we are the voices that matter the most because every single day, everyone on this webinar has seen how home health makes a difference in an elder person's life or even young people, kids. Folks with workers' comp injuries, those kinds of things. Home health is vital in the pie that makes up healthcare. It is the least expensive to the Medicare benefit. It is probably the most impactful. It allows folks to stay at home, and we need to be better stewards of this benefit and better stewards of agencies and better stewards of what kind of care is provided. So I just want to say thank you so much to Summer and Judith for joining us. I am just absolutely in awe of the work that they do. And I think that you can learn a lot from them about how you can be as impactful as possible with the limited time that you have to address some of the issues such as staffing, such as utilization of your clinical resources, such as the ownership issue in our space. all the things that are going on and the use of data in a way that's a practical, appropriate way to use data. All of these things matter. And I thought that it was important that we got some experts together and had a really lively discussion. So thanks again, ladies. I look forward to listening to you myself. And I hope that everyone enjoys this. And again, a reminder, if you have any questions, please use the Q&A box. If you can't get to them today on this session, we will absolutely get to you via email.
So with that, we're going to bring you on, Summer. Before you go to your content, if you can give our attendees a little bit of background so they can understand the depth of your expertise in this space.
Great. Thank you, Cindy. My name is Summer Napier. I am an RN by trade, have my master's in healthcare law. I'm speaking today on behalf of the National Association of Home Care and Hospice. I am operating as their director of grassroots advocacy there. I also own my own home health agencies and hospices, and so I also have experience as an operator for the past 7 years, and then several years before that, overseeing some large agencies. But as far as speaking from the National Association of Home Care and Hospice, I actually fill that role of the Director of Grassroots Advocacy because of exactly what Sherry was saying. There is such a big need, and I know that a lot of us, as an operator, we didn't really have a lot of time to get out there and what we could imagine as advocating. Like, we sometimes think it's just, you have to go to the Hill, you have to, fly in, do all this big to do all of the time, when it's a lot of little things every day that really add up. And so I really felt the need to come in as an operator and kind of help, steward that and just be a resource to people. And so I absolutely love the work that I get to do with them. But from an operator standpoint, I feel all of your pain. I'm in the trenches with you, and so we can talk about all of that. So I think today we're going to talk about the top 3 issues facing the industry right now. Obviously, you guys know all of them, and we're going to talk a little bit about how I would suggest advocating for them, what I do every day, and what I encourage. I'm not going to go too in depth with the first one, because if you are an operator on this call, you know the workforce shortage. I don't need to spit out statistics to you. You deal with it every day. You're having the trouble hiring. You're having the trouble staffing the patients that you do have. It's a big issue, especially for me in the metropolitan areas, because the rates are so competitive. We're still fighting, from nursing and therapists, some of the contract therapy, volatility there. And it's just a damper. It's a huge damper, which also leads into 2 and 3, right? So the second one, obviously, for the home health is the cuts that we're facing. We already received half of those cuts this year. We know that it's coming again from the proposed rule. And the final rule is that at the end of this year, we're expecting to have the other half of those cuts. And when you look at number 1 and you look at the workforce shortage and you see that we're already struggling to compete with everybody, what are we going to do when we also have those cuts, furthermore? And so we are going to talk a little bit about what you can do for the cuts. And then lastly, just to kind of sum it up today from my standpoint, is the hospice integrity issues. On this one, you can see, my stance for it is that if you're not part of the solution, you're part of the problem. And when there's a bad player in, it makes all of us look bad. And so we're going to talk about how you can get involved and you can have a voice in what's to come. You can have a voice and hopefully what the OIG's going to be proposing. And we're going to see some real life scenarios of how you can physically be a part of the conversation and make sure that it doesn't just happen to you. So go to the next slide, please. Thank you. So the first thing that you can do for all of these is just to know your data. As we talk about, advocating, one of the things I wanted to point out is I said briefly, a lot of people don't truly understand what advocacy is. When I first started building an advocacy team in my own organization, people were like, whoa, 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 I'm not qualified to do that. I don't know the government. I don't know politics. I don't know any of it. And I want to just encourage you to dial that back and just truly look at the definition of what advocacy is, which is just the process of supporting a cause. And you do that all day, every day. You show up, you are called to this industry, you take care of these patients, you give them healthcare in their preferred place, which is their home. We have better quality outcomes. We, save on costs. It's just what we do. And when you get confused about what advocacy is, you're diminishing your role in it. And so I want to start there and focus there, in that Every day you're advocating. Every time you admit a patient and you bring them home, you're advocating. Every time that you have a great place to work, you're advocating for the home health industry and the home-based care industry. There's power in bringing data into that. So before we talk at the end of getting to know your legislators and what you have to do with them, let's talk about what kind of data that you can start tracking or that you can know internally to prepare you for some of those conversations. There's power in that data. So for example, let's go back and talk about the workforce. So with the workforce, what do you need to know? So when you're going to go talk to your legislators and you're going to, do some of those strong advocacy activities like that, what do you need to say to them? You don't need to spout out all of the data for the industry. You don't need to know everything the National Association of Home Care knows or what Judy knows or Sherry and City. You need to know specifically of what you're dealing with every day. What's your turnover rate? Why are you losing people? Is it because you can't compete? How many open jobs do you have? How many patients have you had to turn away because you don't have staff? Bring that data to them. Bring the fact that you've had, 10% of your nurses leave for, travel contract, but yet here you go again trying to cut our rates. We're never going to catch up that way. Know that data. Know the stats, recite them. If there was a 4% cut, what does that look like in your agency? So for me, whenever I go and I talk to legislators from my agency-based hat, I will go in and I'll say, listen, if we get this other cut, that might relate to me laying off 17 nurses. And if you know that 17 nurses have a caseload of 40 patients a week, then you can do the math of how many patients in your district are not going to have access to care. So they don't care about all of like the big to-do. They care about you in their district, which patients are not going to get taken care of, what agencies are going to go out of business, why. Another thing about data that we don't always talk to, which is kind of uneasy, but it's very true, and our leader Bill always says, we have to take an internal look at ourselves. As you know, MedPAC will come in and they're proposing, the cuts because of cost report data. Well, a lot of times agency owners don't even really know what's in their cost report data. And so because they didn't take the time to know that data, they didn't take the time to work with their accountant to know that they were putting the right cost in the right places, then these things are happening to them because they don't understand the data that they're sending to CMS is not right. It's not all inclusive of the care that's being provided. They really didn't know what it was. They're sending it, they're outsourcing it or sending it to their CPA and letting them work it instead of you really knowing what goes into it. And so you have to know your data because your data leads to questions. And so when you come in and let's say you have a meeting with your legislator and you're going to get a 4% cut and you're talking about what this looks like and they come in and they say, well, I show that you have a 30% profit margin. Well, you should be able to come in and say, but let me tell you this, I didn't include my telehealth cost in there. I didn't include all of my supplies because let's just be real, maybe I didn't understand the difference between routine and non-routine supplies. There's so much that goes into it that you don't realize, and it's causing impacts that you can hopefully prevent or show up and share the data. And the last one, or the second last one before I get ready to turn it over, is just showing up. Like I said, in my agency, when we started really getting involved in advocacy, people were nervous about going. I would say just attend. Go to these events. If you have a fly-in, go to the fly-ins. If there's a webinar like today, show up, learn, go to networking events. When your legislators have, fundraisers, or if they have dinners and get to know them, or they have like a town hall where they want to know what the issues are that are facing their districts, go. You don't have to speak until you're confident, but go, learn the lingo, build some relationships, make your face known, become somebody that they see. And then after you feel a little bit more comfortable, start being a frequent flyer in their offices. Share emails with them, like when you have, a report that speaks to like the NORC report that shows, that hospice saves Medicare over, billions of dollars a year. Share that with them, shoot them an email, keep them in the loop of what's going on. They're going to see all of the negative feedback and all the negative publicity, but you should also share the positive. And when there is a negative to be shared, let it come from you with real life scenarios of what's happening in their districts. So I could talk about this all day. This is what I do, but these are just 3 of the things that I would recommend that you start with on getting involved, because like I said, you can either be part of the solution, and if you're not, you're part of the problem. So I'll pass that on.
Well, Summer, we have a few more that you had originally sent with respect to these here.
No,
I know we had originally sent 3, but you sent 6. All I did was split them up so you had more room to move. So
oh,
the
I
floor is
love it.
still yours.
I think that some of them will come and go as we talk through the panel, but as part of making your requests known, that comes into your data. And so everything that I've said before about, making your requests known, being consistent, and being willing to step out of your comfort zone, when you make a request known, you have to do that by the data that I spoke about. You have to know what is really going to happen in your agency. So often in many organizations, things are so siloed that you don't really know what's going on. For example, I talked about the cost report data. Until a couple of years ago, who did the cost report data in my agency would have been my revenue cycle team that worked with my finance team, and they just pulled a bunch of reports. And then as I got, more active into advocacy, and I realized, wait a minute, we're sharing information that may or not be correct, because let's just be honest, we love our EMRs, but the data in them is not always great, right? They don't always put things where they need to go. They may not understand what you're asking or the report that you're pulling. So you have to use that data to make a true request known. When you go ask Congress to stop your massive cuts, they're going to want to know why. They're going to want to know, why do I need to stop these cuts when I'm showing that you have this profit margin? Again, going in and being consistent with that is, we talked about, knowing your data. We talked about making sure that you're showing up in those events and you're getting familiar with it and you're meeting with your legislators. Does that mean that you can just go once a year? If you go to a fly-in, that you can just go to that fly-in and that's like, you get your little check mark, you were an advocate for the year? No, you need to become so familiar with your legislators. You need to become so familiar with their legislative assistants. You need to, they need to see your face and automatically think of home-based care. If they have a bill come across their desk and they want some input on it, or they really want to know what this means to people in their district, they need to think of you. They don't need to have to call somebody, at the national level. They need to know, okay, I have met with Summer. She's in my district. She covers this many patients. I'm going to call her and see what this impact would be for her. And then you also, by doing that, you have to be willing to step out of your comfort zone. One of the things that we had happen in our agency is we started an advocacy committee, and all of these people were excited to get involved, but they also were fearful because they didn't know. And so we started by baby stepping them and giving them some opportunities to share things, sit in on some calls, learn, see the one pagers that I believe we might share as a resource for this webinar. But bring them with us also. So we would pull a couple of people from that advocacy committee that has never been to DC, never been to a legislator's office, and we'll take them with us. Every time we go, we take somebody new, because it's just getting them out of their comfort zone. Until you do it, you're scared of it. And then when you do it, it fires you up, and it gets you excited, like, oh, I do have a voice. This is my country. This is my state. This is my industry. What I say matters. I provide this care. And so we just pull them out of their comfort zone and take them with us. Also, social media. People don't have a problem sharing things they shouldn't necessarily share on social media. Maybe you're fighting with your husband, or you share a post you think is funny, but there's power in social media. So when you see Cindy and Sherry, come out with an action alert, or you see Nat come out with an action alert, share it. Even though you may think that nobody cares, there are people that care about what you're doing, and they care about the things you're caring about. That aunt that's 3 states away, maybe she's going to send, an email to her legislator asking them, to support home-based care. So step out of your comfort zone, use your social media, host events also that highlight the work and the devastation that these issues are going to cause. For example, if you are in a metropolitan area, you could couple with a couple of home health agencies and maybe hold a luncheon so that your doctors and your hospitals could come. One of the things that I said earlier was talking about the home health cuts. They're massive. You can see that the referral rate is up to 70, like rejection rate is at 71%. So yeah, these hospitals care that they cannot get people out the door because home health can't accept them. And so work together, band together with some of your post-acute care providers and your referral sources, and be vocal about it. So did I have
Summer, if I can interject.
Yeah.
I want to just interject there because it really struck me in looking at your slides, that piece about our friends and family. I think sometimes we just think this is a within a certain industry and that's who this is meant for, and then we have to advocate only if we work in this space. But we have friends and family that let's just be honest, many of them don't even understand what we do. So it would be helpful to educate them as well. And how many times have we been at a family event and we kind of explain a bit of what we do and they're like, really, that's available? And I know somebody who could benefit from that. And then if they understood things that threaten that or negatively impact that, getting their involvement could be huge. And I never really thought about it that way until I saw that on your slide. I guess I was thinking more in terms of, getting our internal folks motivated, but there's a whole group of people we may not even have considered that could be passionate or may have that relationship with a legislator or a local person that we weren't even aware of until we had that conversation.
Whenever we have an action alert, we will go through the list and we will actually sometimes have like internally drawings to say like, hey, whoever can get the most emails sent, right? Like call your grandma, call your ex-boyfriend, call your ex-boyfriend's new girlfriend's brother. We don't care. We just need somebody to let their legislator know that home-based care matters. And the more voices we can get out there, the better. So thank you for that. I think it's super important. We do overlook it. They care about the things we care about. I care about the things that my friends and family care about. And especially when the work that we do is so meaningful, I sometimes joke around because we need people to sell toilet paper, but we don't sell toilet paper. We save lives. And when you do something like that, of course, people care about it. When you're changing the world one life at a time, that's a mission that anybody can get behind. And so don't discount or rob them of the opportunity to get behind something bigger than themselves. And so before I pass it on, we are going to share some resources, I think, at the end. And just, when I talk about building competent advocates or I talk about putting yourself out there and knowing the data, there's a lot of resources out there that just are conversation starters for you. For the workforce one, there's a Mission Care Collective report that is huge that we will attach. Same if you go to the NAC Advocacy Center, there are a ton of different one-pagers that spit out facts and data. But again, while you have that, I also want to encourage you to take those one-pagers and that data and drill them down to what that impact is for your agency so that you can really talk to your legislators on a district level. And then the NORC report also shows the hospice savings, and it gives you some opportunities. Like, let's say when you want to get involved in advocacy, but you don't know how, people will say, write a letter to your editor. Well, I'm not an author. I'm not great at that. So if I can copy and paste something, I'm all in. I'm going to work smarter, not harder. And I know that a lot of you out there are hopefully a lot like me, or at least say you are, so you make me feel better about myself. There's a ton of resources out there. So we just want to make sure we get those into your hands.
Summer, we had a question come in, so I'm going to go ahead and ask it now.
Okay.
Are there current NAC programs or efforts to help home health agencies more accurately capture their costs? The industry's reported high margins are difficult for clinician advocates to counter and make clinicians wonder if payment is the real problem.
Yes, there are. We're getting it scheduled from the NAC level, a webinar on the cost report data and how your cost report is your best tool. I think that one of the biggest mistakes we make in the industry, and I love this question, is that we don't drill it down to the field staff level. Like I said before, we silo things. And so if we make the field staff stay in the field staff and we don't let them into really how our business operates or what costs are or what we can and can't pay for and what goes into all of this, then how are they ever really supposed to understand? And so, like, for example, just last week, we had a therapist placing orders for, like, you're going to laugh at me, but I don't really know what this is, a carrot finger for OT or something like that. And I was like, hey, this isn't covered under Medicare. We can't provide this. And so they didn't know, they don't know what the Medicare benefit pays for and where these costs are. And so what we started doing in our agency, not at the NAC level, at my operator level, is we started an operational excellence program this year. So that way they can understand the business of healthcare. They understand how we get paid, what a LUPA is, what the HERG score is, how it's calculated, what their diagnoses are, and then where all of that money goes in the company. I think obviously I'm an entrepreneur, so I can't speak on behalf of public companies. But for me, I'm not afraid of transparency. I want our staff to know where the cuts are. And so when the cuts came out at the end of the year, what we did was we showed, okay, we're going to lose about $1.5 million this year with these cuts. I don't want you to feel that. So I want to give you some autonomy in what that looks like. Where do you want, where's your voice in this? And when they saw those numbers and they saw what that meant for patient care and access to care and if we could or couldn't hire, they got on board real fast. They started blowing up social media, their legislators getting involved. But from the National Association level, there information out there. We are continuing to put more out there for you. And if there's something that you need that you don't see, please shoot me an email and I will get it for you or get a webinar put together for you with some resources that we can talk through.
Thank you very much, Summer. That's a lot of food for thought. We also wanted to make sure, as Sherry and I were talking about this idea, that there's advocacy for the industry, but we can't lose track of advocacy for the beneficiary, because sometimes those feel almost a little bit at odds. And anytime I think about advocacy for the beneficiary, only one name comes to mind first, and that is Judy Stein. So I'm so glad you're here today, Judy. If you want to give folks a little bit of background on yourself before you start, that would be great.
Sure, absolutely. It's a pleasure to be with you, and I enjoyed hearing your remarks, Summer, on working with NAC as a longtime goal and opportunity for us. So I'm Judy Stein. I'm the founder and executive director of the Center for Medicare Advocacy, and I'm an attorney. I've been representing older people and people with disabilities since I began my law career at Legal Services in 1975. And founding the organization that I now lead, the Center for Medicare Advocacy, in 1986. I came to focus on Medicare because my work in representing older people, people 65 and older, led me to understand years ago that people who are in that age group and people with significant disabilities often need to rely on Medicare for payment for the services, healthcare services they need. And quite frankly, there were very, very few people representing beneficiaries to make sure that Medicare covered what it was promising to cover under the law, and that there were folks looking to see that the program remained strong for the future as well. So the Center for Medicare Advocacy is a nonprofit law organization. We're staffed by attorneys, a nurse consultant, advocates, paralegals, and information management folks. And we do policy and sometimes what's called class action litigation based on what we learned from speaking to individuals and family members who need care and can't get Medicare to cover, who call us or contact us every day. So it's all based on our direct service work, in which we speak or assist over 7,000 people every year. So we're a very kind of holistic organization that represents the needs of Medicare beneficiaries. And as I always like to say, we don't have any skin in this game. We don't make more money by talking to more people. So we're a nonprofit organization. Our only goal is to make sure that the Medicare program is meeting its promise and expectation under the law, and that frankly, good people such as Summer and you and Sherry and your colleagues can provide care as necessary for Medicare beneficiaries who don't have another source to pay for this care and will go without it if Medicare doesn't do what it's supposed to do. So I've been asked to talk about some of the challenges. I tried to break it down to 3 that are facing beneficiaries right now, and they won't surprise you, and they relate a lot to what Summer just said. So the first challenge is the inability to access care. And that's for a variety of reasons, which I'll get into, but that's the main problem. People who need Medicare, home health care to continue to improve or to maintain or slow decline of their condition cannot get the care they need at all, or number 2, they can receive only inadequate care, both as to the amount that they need and is ordered, and or for the length of time that they need it. They can't get the care they need for the period of time that's needed, as well as very often insufficient care. Finally, they have an inability to contest these denials, which are based often on an understanding by the provider of what Medicare will cover or not. And as a result of accurate or inaccurate understandings of what Medicare coverage is, folks are told that they cannot get the care, that Medicare doesn't pay for that care. And as we'll learn, Medicare will not allow for an appeal or a contest of the Medicare denial if, in fact, people don't actually get the care. So that's a catch-22 that's built into the Medicare system. If you get the care and it's not covered by Medicare, then you can appeal and see if Medicare will cover it. If it's simply cut off, then it's not, you cannot appeal it into the Medicare system. And the system continues to provide too little care, which impacts payment models. And it also, of course, impacts the beneficiary and a lesser quality of life. So I want to talk now about how we might attend to some of these problems and what you need to know in order to help join in the advocacy that Summer spoke about. We need to see ourselves, if at all possible, whenever possible, as partners. That is, those who provide the care, those who need the care, and, you know, in one's future that may change. I might need care today. You might be providing it to me as a home health agency staff person. You might need it, or someone you care about tomorrow might need it. We need to be partners to get care provided as, and in our case, we're talking about today, as promised under the Medicare law. And again, I'm a Medicare lawyer. Also, we need to know what, and in order to do that, we need to know what Medicare promises to cover under the law, what people should be eligible for. And I know that that can be different from what you have to deal with in practice every day, what the Medicare agency, CMS, and its contractors may grant or deny. But I can tell you that under the law, the restoration potential, the ability of an individual to improve, is not supposed to be the deciding factor in deciding whether Medicare coverage is available. In fact, under the Federal Code of Regulations, which is law, it states even if full recovery is impossible, a patient may need skilled services to prevent further deterioration or preserve current capabilities. And the key is going to be, as we talk, whether the skilled care is needed, not whether the person is going to improve sufficiently, improve quickly enough. That's not the deciding factor. Improvement is not required in order for a service to be considered skilled, and it's skill that is required in order to trigger the opportunity to get home health care covered and should be then provided. This has all been reiterated by a lawsuit that the Center for Medicare Advocacy brought in 2011, which was settled in 2013, called Jimmo versus Sebelius. And the citation to that was on the previous slide. And so we brought that lawsuit because, well, we knew we could do no harm. People were being told constantly that they had to improve in order to get Medicare coverage. And as a consequence, people who provide home care believed and still believe dearly that Medicare doesn't cover services that aren't going to improve someone's condition. So we brought the lawsuit on behalf of a woman named Glenda Jimmo in 2011. And the Jimmo case was settled in 2013 with the Medicare agency, CMS, and it came to the conclusion and agreed by court order that that home health services can be skilled and therefore covered when needed to maintain, prevent, or slow deterioration, or when a skilled professional is needed to make sure the services provided are safe and effective. And it's something I've really urged you as care providers to really think about and respect what you know, what you do. And what you do will not necessarily be safe and effective if it's provided by a family member, if it's provided by some elder person's elder spouse who may or may not be that well as well. So if it needs the skill of a professional to be safe and effective, regardless of whether the service is to improve or to maintain an individual's condition, it may well be coverable under Medicare. And that applies to therapy, speech, language pathology, as well as to occupational therapy, as well as to physical therapy, and to nursing. And as a result of the court-ordered settlement in the Jimmo case, CMS, the Medicare agency, was required to revise all its policy manuals that affect outpatient physical therapy, home health coverage, skilled nursing facility coverage, and inpatient rehab hospital facility coverage to reflect these standards that I just provided to you up above. So how can you know if Medicare coverage should be available? That's the basic right there. And even if you cannot, as I'm now going to start reiterating, provide the service for some reason, please don't tell people that Medicare can't cover it, or doesn't cover it, or doesn't pay for it, because they will then think that they have no recourse. Next slide, please. So let's spotlight home health care for a moment. Under the Medicare law, what can be covered and what are the standards to receive Medicare covered home health services? Well, on the left-hand side of your slide, you see the triggering, what we call the triggering criteria, standards. Person must need skilled, intermittent skilled nursing or skilled therapy, physical therapy or speech language pathology services to trigger services. And if the person doesn't need any nursing and doesn't need any physical therapy or any speech therapy, then Medicare won't cover home health care. If the person does need those services and receives them, then Medicare will cover those services and will also allow occupational therapy to be provided, and that will allow therapy services to continue. So those are the skilled services that are necessary to be in place in order to start home health under Medicare. And it requires also that the individual have an order from a doctor or a qualifying practitioner, and that she be homebound, which means it's difficult or can't usually leave home by herself or without a device. And if those things are true, so dependent upon that, Medicare will also pay for these dependent services. And that's first and foremost home health aides, which is the part-time or intermittent hands-on personal care that a home health aide provides, and medical social services and some medical supplies. So importantly, you see, home health aides there. And I just received a notice about an hour ago from CMS with new language in a new beneficiary-oriented flyer that said that Medicare covers therapy and nursing. Well, it does, but it also covers home health aides in the home care setting if an individual is receiving and needs those skilled services. So home health aides are the folks who provide hands-on personal care like bathing, dressing, and grooming. And it's often the critical key to an individual staying at home with any kind of a quality of life. Because if a physical therapist or nurse comes in a couple of days a week, hopefully, but there's no home health aides, who's going to get that person transferred in the morning from bed to recliner, for example, back to bed in the evening? Who's going to bathe that individual? Who's going to make sure that if the skin isn't intact today, that the nurse is called, that the person receives a bath? That's the home care, home health aid service. But be clear that under Medicare, those services are only covered if Medicare's nursing or therapy coverage that I just mentioned is also needed and received. Now, homemaker services, which are like cleaning the kitchen or, well, let's leave it at that, is only covered if it's incident to the hands-on personal care. The same with changing bed linens and helping a person with their chores around the house. When the person is also receiving some of these hands-on personal care, that will be covered as long as the individual is also receiving some skilled care. And it doesn't have to be a lot of skilled care. This kind of custodial care provided by a non-skilled person is specifically covered under Medicare, even though other custodial services are not. And that's the citation you see for it down below in the law and the regulation.
Well,
Now,
Judy,
another important piece,
Judy,
yes.
this is Cindy. I
Mm-hmm,
have a question.
mm-hmm.
And first of all, I want to apologize because it said I could unmute by hitting the space bar, and we saw it just made the slides go crazy. So that was on me trying to unmute temporarily.
That's okay.
I
We
just
all
want
work
to
together here.
I just want to interject here about the home health aide because kind of what Summer was touching on earlier about staff shortages. There's an impact on the ability to provide the aid
Mhm.
because agencies are struggling to varying degrees to have aides available. But then we're starting to see some of this shift to we don't provide aid services. We've kind of just stopped doing it. And if a person needs that kind of help, we're diverting them to pay privately for aid services. I see those as two very different things. When you said before, if you're not able to provide a service they're entitled to, you should disclose. But do you see a difference between trying to manage a staffing issue versus saying we don't provide it and not really telling the person their options?
Yes, that's a huge problem. And even worse is if a person is told Medicare doesn't pay for that, because then a lot of people can't pay for these services, and that's the end of the discussion from their point of view. It's very important that it be clear that frankly, I think that Medicare should pay adequately, and I'm not a payment expert, so that Medicare covered services are provided by Medicare certified providers. It's a public trust. And I will always join with industry to help, if I can, to help understand the payment model and to make sure that agencies are paid for the services that are covered under Medicare law. But if they can be covered, if you happen to have enough funds to pay for them, don't tell the beneficiary who's calling that Medicare doesn't pay for those services. Be frank about what the problem is so that they might go to another Medicare certified agency and try and find the service. So that the service might be provided so that in the end, this circle of underserving people doesn't keep going into the payment model. And by that I mean the less care you actually provide, the less care will be in those stats that are looked to define what payment is necessary to pay for services provided by home health agencies into the future.
And
So,
Judith, this is
excuse
Sherry.
me, yes, go ahead.
Excuse me one second. I think that you just nailed it on the head. I think that the struggle that you, me, Cindy, Summer, and many in many in our industry are seeing is we're getting to the point with these cuts and these proposed cuts that being able to afford to provide the level of care that we are told that we should in the regulations and in the meetings of the regulations, we're getting to this point of no return. And I think agencies are feeling that. They're feeling the struggle to cover their day-to-day costs and to cover the costs of the increasing costs of providing aides and nurses, because they're competing with places like hospitals that we know are running banners over a beach, promising $25,000 sign-on bonuses, because the hospitals are in the same boat as the home health agency, and the home health agency looks at those banners and goes, wow, how did they afford that? Because home health works on such a more narrow margin. But I think I'm going to just kind of reiterate what you just said. If we do not provide this care and we show less care for the money that Medicare is paying us in the data that Medicare sees every day, it's going to be really hard to combat these cut conversations. And I think that that's probably the crux of the issue that's going on. I don't know if you guys agree with me, but I think that that just, you kind of summed it up right there when in that last statement you made, Judy. So I apologize that
Oh, please. I mean, I think it's a self-fulfilling prophecy.
I'll
You,
speak.
you say, you know, you're not, we handle hundreds and hundreds of cases every year for home health beneficiaries. And we did a survey of over 200 home health agencies in 20 states summer before this last. And people are being told that Medicare doesn't pay. You may mean, industry, that it's not sufficient payment to cover your expenses to provide home health aides. But it's not true that Medicare doesn't cover home health aides, and Medicare thinks that its capitated payment system should be sufficient to provide all the care that his individual has ordered and actually reasonably necessary, is reasonable necessary. And it's a big circle. The less care, as Sherry just indicated again, that is provided, the less we'll be able to point to what's needed and what it actually costs to provide that with Medicare's dollars in the future. And now families call looking for home health services, and I will tell you, we get calls and contacts all the time. And this happened to me because I am an advocate for my mother. Agencies are more and more saying Medicare doesn't pay for unskilled services. Medicare only pays for a nurse or a physical therapist. The occupational therapist will provide a bath once a week for people with ALS. This is I get very passionate about this. It's not a way for people to live. It's not true. And in the end, it's going to create further problems for us to work together if the problem is inadequate payment to the industry. And I'm going to have on one of my slides an issue, a statement that was issued by CMS. I know in part because we proved to them right after the PDGM payment model came in that patients were being told that Medicare coverage criteria had changed and therapy wasn't available any longer, and home health agency aides only paid up for covered for a bath now. And that's not true. It's not true under the law, and people start getting less care than they need. And then the agencies can't prove that the cost of providing care is what it really is when the payment model comes up for review. So,
Summer, did you have something you wanted to add in there? I think I heard you trying to.
I'm sorry, I didn't mean to.
That's okay.
No, you're fine. I can save it to the end, but be very specific that right now I'm speaking not on behalf of NAC, but on the provider level, because I know there will be questions regarding this. So Judy, what I feel like I hear you're saying is, while agencies can't provide, the aid services at the level that Medicare is supposed to cover the aid services, when they're saying Medicare doesn't supply it, what you're suggesting that they say is that I would love to supply this for you, but I do not get paid enough, not in that way, but in a politically correct way. The coverage payment system, reimbursement system does not cover adequately staffing for me to provide the services that you are entitled to. So from an advocacy standpoint, we could get our patients involved in saying, you do need this coverage. I would love to provide this for you. If I provide it for you and every other patient that deserves it and should have it under the Medicare Trust Fund, I will go out of business within 6 months. So how do you suggest operators balance that? Because if they do, speaking from experience, if I were to put a home health aid in on every patient that wanted it or deserved it or needed it at the level that Medicare says it should be covered, then I will be out of business in 6 months because the payment rates do not take care of that for me. So what would you say to the operators on the call that are going to struggle with this?
Well, it's a complicated answer on my part. Talk to Bill Dombey, who I worked with for a few years and on and off for decades now as colleagues. It is. I'm not a payment expert. I do know I've been doing this work for decades now. It's my sole work. And it's not just under PDGM, and it wasn't just under PPS, and it was much better under payment per visit. But people used to be able to get these home health aid visits, and they weren't told that Medicare was just a skilled service. And it's becoming a reality. The reality of what the next payment model will be, I think, will be a few maybe therapy, and we hear it's duplicative. PT is not the same as OT. You know, I'm a lawyer and I know that. Fight back. It's not duplicative. And home health aides are part of what people need. And nursing is not the same as therapy. And OT shouldn't be coming in and doing the nursing work and doing the home health aid work. So what should you say? I would ask you to say that Medicare coverage is available for home health aides, but we don't have them for Medicare beneficiaries. And it's that is apparently, if it's true, then that's the truth, but it's not true when if they have the funds, they can call a sister or brother agency or a sibling agency and get the aids provided. It's the place where the rubber meets the road, where it may feel like what I'm telling you is not in reality, not reality based, but you know, I know that people are told, if I provide it to you, I can't do what Mrs. Smith needs. But that's no answer when someone's Mr. Brown, or when I'm calling from my mother and she's told she can only get a bath a week because otherwise the neighbor can't get a bath. Now, if it's not needed, that's different. I'm not talking about what people want. I'm talking about what people need. And I hope it's a place we need to figure out how to join the voice of the people who can represent just the beneficiaries. I mean, I run a business. It's a nonprofit business. I got to pay for my staff. I got to keep the lights on. It's not easy, and I understand that. But it's also necessary to tell the truth to people so they don't start thinking that Medicare only covers skilled nursing or skilled therapy. Or worse than that, only pays for a nurse or a therapist if you're getting better. That's what they, at the bottom line, what they think is true.
Right. I think that your clarification of how they answer that question is very helpful. I think from the operator's side, it would be more of a concern of sacrificing the one for the all, and that's a horrible way to put it. But I think that these conversations are very much needed, and I think that we can't silo either one off, and we have to keep having these conversations until we get Medicare to the table to see what we're really doing.
Absolutely.
And
the
that's the
policymakers need to hear it.
And that's the traffic we're seeing in the chat box, because people are very much admiring the passion on this, but may also be looking and saying, oh, there's only 5 more minutes left. If you have to leave us early, we are recording this in its entirety if we go a bit over. So you can listen to the recorded version and won't miss any of it. We don't want to cut people off because, like you said, Summer, this is an important conversation and a difficult one. But I think a key element of what Judy said was we have to keep in mind this is about what patients need and not necessarily what they want. And sometimes when it's into this, people, you know, well, because I'm having this, I want a home health aide 3 times a week. If you don't need it, I'm not compelled to give that to you. So but I think it's a conversation we have to have.
Cindy, what's needed? I mean, let's not.
Correct.
You know, people. You know, when I'm sick, I really want to get a shower, and as soon as I get showered, I feel better. So I'm sorry to jump in, but want and need are complicated words, but we can't diminish the needs of an individual because they're at the behest of someone else to do it for them. And that's what I think is happening.
I have a great, really brief example of want versus need. When I was an agency owner, we had a person who had a colostomy, and they'd had it for years. But as we know, colostomy supplies are under the bundled services that are covered under home health. The gentleman had colostomy supplies that basically, I think, were lined with gold. I think, honest to goodness, they had the seal that was sealed with gold. And as a young agency, we were not as aware of some of the supply issues that were going on. So we were providing him with the with the colostomy supplies that he had become accustomed to, which were something like 7 times the cost of adequate colostomy supplies. And we learned very quickly as an agency that he wanted the expensive supplies, but what we provided was the needed supply. And so having that tough conversation with the beneficiary is super important. And it's very, very difficult when on the other hand, you may see agencies in your own town that are cutting corners for the beneficiary and not doing the things that are appropriate for the beneficiary. And that's something where that's again part of the advocacy, right? We need to clean our own house. We need to keep care of our own house and make sure that we're operating within the lines of the guidance that Medicare provides, but also having the opportunity to speak to those legislators and to those surveyors. When we see something, say something. If we see something being done inappropriately with a beneficiary, we need to say something as an industry.
Yeah, I agree entirely. And perhaps we could run to the last 3 slides that I had there, Cindy, and perhaps then that would help folks know how much we, as beneficiary representatives, we're David. There's a lot of Goliaths out there. This shows that the Home Health Benefit Policy Manual was changed by Jimmo, but this is the one I wanted to show you as well, and hopefully the listeners will get these slides. And this is what I mentioned to you that we brought to the attention of CMS in January of 2020 when PDGM came in, how hard it was for beneficiaries, that people were not getting the care just 6 months ago they had been getting. And CMS issued this Medicare Learning, I forget what the N means, matters article that showed that reiterated that the coverage criteria had not changed. And the notion is that the bundled payment will provide enough payment for all the services needed as long as they are needed and meet the coverage criteria. I just urge you not to pretend they aren't needed, because we're going to end up with both the beneficiary getting less care than is really needed and the payment model showing less care that's provided and less payment that's needed going forward. But this, I hope, demonstrates that we are trying to make the coverage criteria stay honest and get payment to recognize it, what's really needed. And then the next slide shows some practice tips with regard to continuing to serve folks who need care, that skilled care that is necessary in order to get the home health care aids to paid. Be certain that the order and goals indicate that what your goal is to, if it is to maintain or slow decline for the individual. Make sure that's in the documentation. If improvement was originally expected and that goal is either met or changed, get a new order or the new goals so that the order and goals reflect what you're providing. And then, because otherwise we see Medicare denials occurring, and we want you to be paid, and we want the beneficiary to get the care. As a pragmatist, we know that improvement is what the determiners look for, and I will keep fighting that with you. It's not the sole criteria, but if it is present, show it in whatever way you can. The person doesn't need to return to their prior level of function. If they can now shift in bed and keep their skin from breaking down, that may be improvement for them that you want to note in your record. Also, document the efforts to maintain or slow decline. Document, document, document. And then next, finally, that's one of my, what can you do? Know what Medicare coverage is under the law and believe it. That's what I'm urging you to believe it. Know what I'm telling you is true, and that I know it's a battle, and I know you're being kind of forced to do otherwise. Don't be forced to say otherwise. Provide the necessary care, whether it's to improve or to maintain or slow the individual's condition. Beneficiaries, note that beneficiaries can't appeal if the care isn't provided. So provide the care at least in some cases. And then I should have had another bullet here that says, submit the claim. At least fuss with some of these cases where you know this individual needs this care. Provide the care, document it, and submit the Medicare claim. And if we can, because our resources are limited, we'll do the best we can to support a case that goes into the Medicare system for a beneficiary who meets all these criteria. But remember, they can't contest if the services aren't provided, and they can't contest if the claim isn't submitted. And we have a lot of resources on our website. I particularly want to tell you to look at cms.gov, put in the search engine JIMO, and you will find something with this CMS logo that says much of what I just said with regard to improvement, care being covered for maintaining a slowing decline, and that you can include that in your documentation. Point it out to those who are making erroneous decisions that then hurt you as a provider in your attempt to provide necessary care. I hope all this is very helpful and you see us as both a resource and an ally. Thank you.
Well, today, we kind of got together to put together today's content. I had a bit of a vision of how this would come out, and this has exceeded what I had hoped. What we've seen is it's not an easy conversation to bring the industry, advocacy, and the beneficiary together. There's difficult conversations, and there was a lot of activity in the chat box, people sharing strategies about developing tools to determine need for a home health aide and helping families better understand. A lot of kudos for the passion of both Summer and Judy and their participation today. I feel like this may be a future part 2 discussion at some point, but I really want to thank Summer and Judy for your willingness to share your time with us today. I think if nothing else, we should, each person participating should have gotten fired up about at least one element of this, and now can figure out, I need to make my voice heard, because my big takeaway was an extension of what both Judy and Summer said, that if we don't provide the care, if we don't stand up, if we don't say anything, the payment continues to decline. People assume that we're all okay with it when there's only 100 comments out of 10,000 home health agencies. And we really have to get involved if we're going to make any attempt to make this better for the people that we serve.
Absolutely.
So you have our contact, oh, not that, what on earth. I have our contact information, and yeah, the recording of this is sent to all registered attendees and will be available on our YouTube channel, and the handout will be associated with all of our contact information and the information that was today. If you have any other questions for any of us or all of us, you're able to find us via our email. And I want to thank you all for spending some time with us today.
Thank you.
Thank you, Summer. Thank you, Judy. It was a lot of fun.
Good.
It was a lot of fun. Thank you so
glad.
much, guys.
Thank you. Thank you so much.